So we're now introducing the 2 free papers for the WReN session, and I'm delighted to invite Ros Lathan, who's a lecturer and a clinical research fellow up at the University of the West of Scotland, who's going to talk about the current practice of surgical site infection in vascular surgery. So welcome, Ros.
Yes, as mentioned, I'm going to discuss the recent survey that we'd done of the current practice of surgical site infection prevention in UK vascular surgery. A bit of background: surgical site infection as a variable incidence, as we discussed, but in vascular surgery, in some literature, it can be up to 40% in certain procedures. Understandably, this causes significant morbidity and mortality, and it has recently been identified as a top 10 UK research priority in a Delphi survey. In 2014, a survey that investigated perioperative surgical site infection prevention measures in lower limb amputations demonstrated a lack of consensus in how these measures were used. And the Getting It Right First Time survey also analysed surgical site infection prevention practice across a number of surgical specialties, but there was little data from vascular units in that, and only a few surgical site prevention practices were presented here. There's been a number of guidelines produced in recent years for surgical site infection prevention from the NICE, WHO and CDC. So we therefore aim to survey the current practice of surgical site infection prevention among UK vascular surgeons. And to our knowledge, this was the first comprehensive survey to review these practices in vascular surgery since the guidelines were produced. So as mentioned, the WHO, CDC and NICE have all been analysed, and we produced 15 question topics for surgical site infection prevention. So the yellow areas in the table indicate where further research was highlighted that it was needed before a definitive recommendation could be made. And interestingly, there's almost no agreement across these guidelines for recommendations for preventing surgical site infection. So after analysis, a focus group developed a survey taking into consideration additional measures where the guidelines hadn't included the preventative measures. And the survey was then validated across 2 rounds of piloting in a tertiary vascular centre. And finally, 29 questions were presented in 16 question topics across the pre, peri and post-operative phases to the Vascular Society's membership in March 2021. The survey remained open for 1 month with 2 reminders distributed at weeks 2 and 3. So we had 109 responses to the survey in total, 90 of which were consultants, vascular surgeons. And currently there's 376 vascular consultants in the VS membership, which gave a response rate of 24%. And there's good geographical distribution of responses from 47 hospitals across the UK. All members were invited to estimate their overall surgical site infection rate in their unit for the period January to end of December 2019, and the median reported infection rate was 7.5%. So moving on, the 100% of respondents indicated that they submit data to the National Vascular Registry. And whilst the CDC criteria is recognised as gold standard for diagnosing surgical site infection, the majority are using empirical choice to diagnose this. There was good agreement that lower limb arterial and major limb amputations are the highest risk categories for surgical site infection. And 62.7% indicated that there was a dedicated protocol or policy in their unit for surgical site infection prevention. So 2/3 would advise that patients bathe preoperatively. but there's little consensus on the ideal antiseptic, however. And lack of evidence was a key reason that surgeons would not advocate using this. Nearly all vascular surgeons would screen preoperatively for MRSA, but there's little consensus on the ideal eradication treatment. Again, there was good agreement on which procedures should receive antibiotics preoperatively. And that's including both open and endovenous AAA, lower limb arterial, major and minor limb amputations, and carotid surgery. The majority would give antibiotics within an hour of knife to skin. So 84.5% of respondents would remove hair preoperatively to avoid hair in the closure site, which is in line with NICE guidance for this to only be used in surgeon preference and not surgical site infection prevention. And this typically occurs in theatre with clippers. So the majority are using alcohol-based surgical site preparation, but there's less agreement on the ideal type of skin prep, however. So despite evidence and practice trending towards alcohol-based surgical site preparation, the majority use aqueous-based hand wash. Less than half would routinely carry out nutritional assessments. Only forced air warming had good agreement for maintaining normothermia. And there's no clear consensus on the management of blood glucose in non-diabetics perioperatively. There was very little consensus on whether to use wound irrigation in clean incisions, and if using, what type of wound irrigation to be used. The majority of surgeons indicated that they would use gentamicin impregnated sponge. But the reason for doing so seems less clear. Just under half of those using gentamicin impregnated substrates do so for prosthetic implants or reintervention surgery. And seemingly, the majority would not use triclosan coated sutures, with no evidence or these not being available being the primary reason stated for that. Just over half of respondents indicate that they use basic wound dressings, but there doesn't seem to be a clear consensus on the ideal post-operative dressings. And practice seems to be divided on the use of prophylactic negative pressure wound therapy for closed wounds, with just over half indicating that they would use that. And around 2/3 would give antibiotic prophylaxis for less than 24 hours. But there seems to be very little agreement on which procedures that this should be before. And finally, the majority do not undertake formal wound surveillance. So we also investigated the impact of these prevention measures on reported surgical site infection rate estimates, but given the low numbers, there was no significant impact that we could establish here. So UK Vascular Surgery agrees upon which procedures are high risk of surgical site infection. And there's over 70% agreement in a number of surgical site infection prevention topics. However, many of these are only partial agreements, with the major aspects still lacking clear strategies, including eradication of MRSA, specific alcohol site preparation types, and warming strategies other than forced air. And whilst there was over 70% agreement on which procedures to give antibiotic prophylaxis for, to our knowledge, only the Harvest trial has shown a significant reduction in surgical site infection with antibiotic prophylaxis. And this investigated the impact of comoxiclav for surgical antibiotic prophylaxis in open venous surgery. 78% of surgeons in this survey indicated that they were using alcohol-based skin prep currently. Comparing with this with the survey in 2014, where only 48% of surgeons were using that, shows a significant increase in practice in line with recent evidence in this time. Despite good levels of agreement on which procedures are at high risk of infection and the CDC gold standard criteria for diagnosis, the majority are not using an objective method of diagnosing infection. Without a validated, widely accepted and robust diagnostic method, the consistency at registry level and published data can be impacted. Reported infection rates vary considerably. With this study alone, the estimated range was 25% and the median 7.5%. So this could be a key reason for a disparity in reported infection rates. In addition, a significant proportion, 73.7%, of surgeons indicated that they weren't undertaking formal wound surveillance, indicating that many infections may go underreported through lack of direct observation or objective measurement. There is a lack of consensus on a number of surgical site infection prevention topics, including nutritional assessment, non-diabetic blood glucose monitoring, clean incision wound irrigation, and optimal wound dressings that could be used, and prophylactic negative pressure wound therapy. One significant issue is that although the CDC, NICE, and WHO have recently published guidelines, these themselves state that there's a significant paucity of evidence in key areas and a substantial inconsistency across their recommendations. Although there was adequate response to the survey, respondent fatigue was an issue. This was addressed at question synthesis, but the questions were felt essential for the data required. Sample sizes as such were not large enough to draw any meaningful conclusions assessing the impact of prevention measures on estimated SSI rates. In order to preserve the structure of the survey, questions were categorized into surgical site infection, pre, peri, and post-operative related themes. The survey did see levels of dropout towards the end, which may have been owing to the amount of data. Future surveys could then attempt to randomise question order to reduce this dropout. Not every prevention practice was also examined. Aspects such as surgical technique or laminar flow theatres also impact infection rates and could have been, but including so would have increased dropout further. So comparing for future, the plan is comparing the practice we've demonstrated here with estimated surgical site infection rates and the MVI data to give an objective measure of accuracy of estimates. Unfortunately, this was not available at the time of presentation. And the survey also substantiates the necessity for well-designed trials into a number of surgical site infection prevention measures to enable truly evidence-based practice. Thank you.
Thank you, Ross. That was excellent, and a number of recurring themes across different specialties today. So that was really interesting. Thank you. I'm going to move on immediately to Amy Mbuli, and Amy is going to talk to us about, again, recurring themes from today, electronic systems to support new ways of working. So welcome, Amy.
Is that all right? Brilliant, thank you. That was interesting, Ross. I'll just quickly say it's been a bit of a labour of love of our teams for the last 2 years around surgical site infection reporting and getting a team together. So it was interesting, very similar themes cropping up for sure. Thank you ever so much for having us. here today. We wanted to share some good news from what has been a very challenging, well, nearly 2 years now, particularly with the hats that I wear. This presentation is going to cover the service improvements made during COVID and the impact they've had, the positive impact they've had on patients and staff. I thought I was a bit clever with that curtain opening thing. It's funny how you PowerPoint presentations, isn't it? So who are we? Morecambe Bay CCG, which is this main boundary, encompasses districts throughout some South Cumbria and North Lancs. So we're a fairly hefty geographical boundary. We've got 4 main hospital sites and some minor hospital sites. So the IP team cover acute and community, but our tissue viability team cover the acute, and that's these 4 sites. So as you can see there, the furnace general, we've put little stethoscopes. You can see my pointer, my arrow. So the stethoscopes where these hospitals are, but effectively this large boundary from furnace general, which is over here in this orange area, RLI right the way over here, and Kendal, or the Westmoreland site, up here. We've got circa 700 inpatient beds, and I've said circa because particularly at the moment that changes on any given day. About 250 at furnace site, 350 at RLI, and 50 at Kendal. And as you can see, the mileage between them is significant. It's not a short nip from one site to another. It does mean some travel, significant travel across Bay. Not only that, the 2 sites linking together, it's not an easy even train ride or bus ride. So in terms of moving staff from one site to another, there is challenges involved with that. So where were we? A large geography with 2 tissue viability nurses for our acute sites. The 2 tissue viability nurses, so Claire works at the Royal Lancaster site, and then Kieran covers the Furness site and the Kendal site, but it's based at Furness. We had 2 digital cameras, which came with significant IG risks and upload issues, as we used to joke, the handy 50-step process to get from the camera to the our Paperlight patient portal. We had an Excel spreadsheet which became unwieldy and was more laborious than it was helpful, and we required a system for data capture. So the data that we did have was number crunching from a spreadsheet, or it was fed to us retrospectively through an automated report, which isn't very good for if you're wanting a snapshot of current referrals or what's happening on the ground right now. So where are we now? Well, we've still got only 2 tissue viability nurses, but we've made huge steps with our technology. So working with technology we've already had in situ, we got handheld device imaging rolled out. So our handheld devices already on the units were working towards EOBS and all the other Paperlight performers that are being used within the trust. So what that allowed for us to do was add an app onto these handheld devices using the Sector Pack system, which radiology services use. This has been successfully rolled out across the acute sites and is being used consistently and to huge benefit. So whereas before Kieran and Claire couldn't see for some time these wounds, or they had to wait until they actually physically had to go and see the patient, they had no way of that ongoing record. of either wound improvement or what was, or even in homeostasis of the wound, there wasn't that there. So this is really supported with that. They get to see more patients, so they'll just say, right, do your handheld device and I'll look at them today and then I can get out to you on X time. So it's made a huge impact. Staff really enjoy that instant use. So they click into the app, they make sure that the appropriate form is completed, so they're still getting that consent, and then it instantly uploads to where it needs to, so it's instantaneous. Dashboard, a dynamic dashboard has been developed. Excuse me. This combines both our acute and community pressure ulcers, because we do cover both as a trust. We are acute and community. We can focus in on the award, the department. We can focus in on a specific pressure ulcer or of any type, month, date, and whether it's deteriorated within our care. This has been huge in terms of having a report, having this data ready for a report is game changing. The spreadsheet, we now have a dynamic dashboard which pulls directly from the Ulysses, or the incident reporting system, and the e-referrals, which is how Kieran and Claire are requested, goes directly onto a dashboard. This dashboard is dynamic in that Kieran and Claire can access it. They can add the date that they've seen the patients. They can check to say, yes, we want to go back and see them. This has been huge in terms of taking away the IG risk, because previously you were pulling from one system to another by copying and pasting, and it's taken that away, that transposing error risk and IG risk. So what's next? To support with dressing choices, we are using MicroGuide, which platform, which people may or may not be familiar with, but this is previously for antibiotics. So you go on, you look at a body system, or you look at a type of infection you want to treat, and that way we are changing this system and adding wound dressings. So we are then you're looking at a type of wound and then drilling down into the best type of dressing for that. And then the other thing we're looking at is a virtual clinic. We want to, whilst we've got the imaging, we want to do we want virtual clinics, so it's real-time support for negative pressure wound therapy, or just aspects like that to support with the remote way that we work within this trust. And that's it. Thank you very much. I'll stop sharing.
So, but thank you for a really interesting presentation again, and some of the positive things that we've seen from COVID, I think, which we will continue to use during in future clinical practice. So so Linda Primer's just put a question up for Ross. How does he think the identification of no wound surveillance should be addressed going forward? So what should we be doing about wound surveillance?
I think it's very important. I think there's potential for a lot of infections getting missed. We've certainly seen it in practice. There's risk of people getting missed and things getting much worse, and which results in a lot of service burden on other areas when these people do finally present. I think the way of fixing that is probably much more difficult. So, and then there's a lot of interesting work. Like I think we spoke a lot about stuff today, the virtual work is very important in this day and age, and probably one of the key solutions to that is a case of working out the best way of implementing things and making sure it's done in a way where we're looking at what we think we're looking at.
Yeah, I mean, we've done some work in wound healing by secondary intention after excision of skin cancer on the lower limb, and I think what the big surprise, certainly for me, was that there isn't any. The post-op surveillance is highly variable, and some of those wounds do deteriorate and are then classed as leg ulcers. And we found quite a high proportion of patients who had cellulitis and required hospital admission. There was 3 out of 58, which is actually quite, nearly 6%, which seemed like requiring hospital admission after a clinic procedure. And the non-healing rate was, I've forgotten the details. We should hear that tomorrow, actually. But it is a challenge, isn't it? And we should be using electronic records across both primary care, community care, and secondary care in order to capture some of this data and some of the technologies that we've been talking about this afternoon. So yeah. Thank you for that. Oh, there's another question popped, I think. Is there? No. Oh, there's a question for Amy about experiencing IT system problems.
Initially, when we first started rolling out the handheld devices, there was certainly some things to work through, and that was definitely part of the process. The Wi-Fi was boosted along with our paper light systems. It was very much understood that we needed a very robust Wi-Fi. We do have remote sites, and particularly Furness, the building, I think, has got lead walls because we do struggle with any 4G through the corridors. So certainly initially, but as we've rolled this out, we found actually that by supporting with the Wi-Fi and other things that we've worked through those glitches. The trial period was absolutely worth it. So Kieran and Claire went out and were just doing it for a couple of months before we rolled it out further, and that made a huge difference because it was generally Claire picked up all it always happened to her was, oh no, I've just taken the photo and now it's gone. But yes, absolutely, we're much better.
But you've worked through that. That's great. So, well, I'm delighted to bring this session to a close. So thank you, Ross and Amy, once again, and the other speakers earlier in the afternoon, representing the Wounds Research Network and the activity that's going on in the UK and also internationally in wounds research.